Thank you for joining us. My name is Audrey Hassan, Patient Liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Prapti Patel, a professor and hematology specialist at the University of Texas Southwestern, an MDS Center of Excellence. She specializes in the treatment of myelodysplastic syndromes and leukemia and in providing bone marrow and stem cell transplants for those patients. With that said, it is my pleasure to introduce Dr. Patel.
My name is Prapti Patel. I am an associate professor of internal medicine at UT Southwestern at the Simmons Comprehensive Cancer Center, and I will be speaking to you about the treatment of high-risk myelodysplastic syndrome and the indication for stem cell transplant. So first, we'll briefly go over the definition of high-risk MDS, the treatment with hypomethylating agents, the indication and the process of a stem cell transplant, and also some clinical trials that are available within UT Southwestern and also that are available all over the United States. So in terms of the definition of myelodysplastic syndrome, there's a few predominant features that we see with patients that have MDS. The first one is something called ineffective hematopoiesis. So what that is the inability of the bone marrow to make normal bone marrow cells. Normally, the bone marrow is supposed to make red blood cells to carry oxygen, white blood cells to fight off infection, and platelets to keep you from bleeding. And this is a very systematic process that starts from a baby stem cell, and these cells slowly mature into the three final cells that make up the blood. MDS is characterized by this ineffective process because the cells are no longer able to differentiate. In addition to not being able to differentiate, these cells also grow at a faster rate than normal. So the bone marrow gets filled up with a whole bunch of cells that are not able to function properly and have a growth advantage of the normal cells that are seen in the bone marrow. The most common presentation of MDS is anemia, which is low red blood cell count, but people can also present with a low white blood cell count or a low platelet count. Treatment hasn't moved much in the past 20 to 30 years. Most of the time, we give a very low-dose chemotherapy called a hypomethylating agent, which I will go through in detail, or we can do supportive care with lower risk MDS with things like growth factors or transfusions. But my focus will mostly be on the hypomethylating agents, as those are the standard of care for high-risk MDS. Also, it should be known that despite there being a treatment option for MDS, it is not curative in terms of chemotherapy. And the only cure for MDS is an allogeneic stem cell transplant, or more commonly known as a bone marrow transplant. And we'll discuss the process of this also. So what is high-risk MDS? MDS really falls on a spectrum, and it goes from low risk to high risk. And it's defined by this score called the RIPSS score. So basically, once a bone marrow biopsy is done, we look at the number of aggressive-looking blasts or otherwise leukemia cells that are seen in the bone marrow. We look at how severe the low blood counts are, so how low is the hemoglobin, red blood cells, and platelets, and also what chromosome abnormalities or what DNA abnormalities are present, because certain DNA abnormalities portend a good prognosis and certain portend a bad prognosis. So doctors are able to come up with this score, but what does it mean for the patient? For the patient, the higher the score, the higher the risk of complications, and the most dreaded thing is the higher the risk to the transformation to acute myeloid leukemia. So when we look at the science of what MDS is, it's really a problem with the DNA. So just to take you through a little bit of science right now, these are the building blocks of DNA. Normally, there's a hydrogen group that sits right there, and when it's time for this DNA code to be unraveled and decoded so you can have good maturation of red blood cells and white blood cells and platelets, what actually ends up happening in MDS is instead of a hydrogen code, there's a methyl group that sits right there. And when there's a big, bulky methyl group that sits on the DNA building block, that DNA is no longer able to unravel. Therefore, all of the genes and all of the processes that are required for these cells to mature are no longer able to function. So the cells just kind of sit there, not able to differentiate, not able to mature, because all of the DNA has these bulky methyl groups on there. And this is really the cornerstone of therapy for MDS. We use what's called a hypomethylating agent. So that chemo goes in there and cuts off this methyl group, allowing the DNA to unravel and allowing normal maturation to occur. So when you're looking at a bone marrow biopsy, what defines MDS in addition to the DNA changes we just talked about in the prior slide? This right here is a picture of a bone marrow biopsy, and there's a couple of things that we're looking at. These right here are platelets, these are red blood cells, and these right here are the aggressive looking blasts. So when a pathologist is looking at the bone marrow biopsy, they're trying to count how many of these blasts are there, because that helps with the prognostication and the calculation of the risk score we talked about. We also look at the maturation of these cells. I'm going to point you to this cell right here in the middle that's got these two little nuclei in the middle. This is called a Pelger-Hewitt anomaly. This is not something we see in normal bone marrow, and it's actually indicative of poor maturation of a white blood cell. So we start to look, when we're looking at a bone marrow, we're starting to look for how many aggressive cells there are, and also how many of these cells are not able to mature properly and are showing abnormal signs of maturation. The next thing we look at is the chromosome abnormalities. Remember, chromosomes are the genetic code for all of these cells, and certain parts of the genetic code are transcribed and used when the cells need to mature. But when there's an abnormality in this genetic code, the cells won't mature properly, or they'll grow too fast and take up the whole bone marrow. So we see that there are multiple chromosome abnormalities that can be found in MDS. Most commonly, though, we don't find any abnormalities. And remember, that's because a lot of the abnormalities lie in the fact that it's just these heavy methyl groups that sit on the DNA code. But there are extra chromosomes that we can see. There are pieces of chromosomes that could be missing, or entire chromosomes that could be missing. And depending on what chromosome abnormality we have, we can prognosticate how aggressive the MDS is. So in this study that was done quite a while ago, they took thousands of patients with MDS, looked at how many different chromosome abnormalities they were, and compared it to survival, and then also compared it to the risk of evolving into a higher grade process called acute leukemia. And we can see here that there's certain types of abnormalities, such as this one, which is correlated to complex cytogenetics, meaning multiple abnormalities, or this curve, which is very distinct from the one down here, which is just a deletion of the Y chromosome. So you can see the prognosis in terms of years can vary quite widely depending on the chromosome abnormality that we see. And the same goes here for risk to transformation to an acute leukemia. When you have complex chromosome abnormalities, the risk to transforming to a leukemia is much higher than if you have something like just missing a piece of the Y chromosome, as you see in this curve up here. The other thing we look at is how many blasts, or how many ugly-looking immature cells are sitting in the bone marrow. And it's safe to say that the more blasts there are, the higher the risk of transforming to leukemia. Leukemia is really on the spectrum of MDS, and it's just one step ahead of the high-grade MDS. So whenever there's more than 20% blasts or leukemia cells in the bone marrow, we call that an acute myeloid leukemia. So we can see here, this is the risk to transformation to AML by time, and this is the percentage of blasts that we see. And we see that the higher the blast count, which is this line down here at greater than 10%, the higher the risk to transformation to leukemia. Whereas if you have 2% or less blasts, there's really no risk to transformation to leukemia. So looking at the chromosome abnormalities, the number of blasts in the bone marrow, and then also how severe are the low blood counts, we come up with this score called the IPSS-R score. So you can see here, depending on the chromosome abnormalities, we assign a point to that. Depending on how many blasts there are, we assign points. And then based on how low the hemoglobin, the platelets, and the neutrophil counts are, we can come up with a score. And then we add all these numbers together and come up with the total risk score. So when you have a risk of greater, if you have a point system of greater than 6, that's very high risk MDS, or between 4.5 to 6, considered high risk MDS. So I'm going to be focusing on these bottom two categories over here. The high risk MDS that has aggressive looking chromosomes, lots of blasts, lots of low blood counts. What are the treatment options for that population of people? So when you look here, and I don't want to focus too much on the survival, we know, and it would make sense based on the chromosomes and the ugly looking blast cells we see in the bone marrow, that the higher the risk of MDS that we have, the lower the survival, which tells us that we need to be aggressive up front to help improve survival of our patients that have high risk or very high risk MDS by the IPSS-R score. So first, we're going to just gloss over the low-risk therapies because this talk is more about this other side, which is the high-risk MDS. But the goal of low-risk therapy is we know that these patients are not going to transform to leukemia. So our goal is really to increase the function of the bone marrow, of the normal cells that are sitting in the bone marrow. And we can do that by giving growth factors and hormones. And we just kind of ignore the MDS cells and try to beef up the normal cells. But in the high-risk situation, that doesn't work as much because most of the bone marrow is MDS cells and there's very little of the normal cell population. So at that point, our goal switches into killing the cancerous clone, killing this bad MDS, and preventing transformation into leukemia. And we do that in two different ways, and I kind of talked about that at the very beginning. The first one is the hypomethylating agents, and the second one, which is curative, is allogeneic stem cell transplant. So again, just kind of picking up where we left off from the beginning, when we look at this little DNA block, we want to have the DNA in this formation with a small hydrogen group attached to the building block rather than this bulky methyl group, which blocks the DNA from being decoded. So the chemotherapy that we have, the hypomethylating agent, will cut this off and allow the DNA building block to go back into this formation, allowing all of the function of the cells to go back to maturation and differentiation mode, which is what we want. So one of the most common hypomethylating agents out there is azacitidine. So azacitidine has been studied for quite a long time, and we have a lot of mature data on this. And I'll only go over the biggest study that we had. So the biggest study is this randomized phase 3 study. So what that means is hundreds of people that were, or 200 people that had MDS were randomly assigned to either supportive care or to this chemotherapy called azacitidine. And then we looked at what percentage of patient had an improvement in their blast count, in their blood counts. And we can see here that when we look at the group of people, the about 100 patients that were on the azacitidine part of the study, the total number of people that improved were about 60%. Whereas those that did not get azacitidine and got supportive care, which means transfusions, hormone growth factors, other types of chemotherapy, the total number of people that improved was only 5%. And we can see here that also when treating with the azacitidine, the time to transform into the most aggressive form of leukemia called acute myeloid leukemia was 21% in the azacitidine group and only 21 months in the azacitidine group and only 12 months in the best supportive care group. So we can see here that azacitidine is actually better than not giving any kind of hypomethylating agent and only treating with growth factors, chemo, or other types of transfusions. However, when we separate out all the groups that were in the azacitidine, we separate them out by their IPSS risk score, we saw that those that had high amounts of or high risk of MDS, their improvement rate only fell down to about 40 to 50%. So we know these patients that have high risk MDS tend to have a more aggressive form of MDS that may not respond to the azacitidine or will only temporarily respond to the azacitidine. So our goal at this point now is to say Well, this isn't good enough for our patients that are high risk, and we need better treatments. When looking at the survival study of these patients, so the 200 patients that were on the study, what was their survival like? We can give them a good response, get their transfusion rate down, but are we making them live longer? And we can see that, yes, we are making them live longer, because at the 2-year mark, the survival rate was 51% with azacitidine. So that means 51% of the people were alive at 2 years when they were treated with azacitidine, versus only 26% of people were alive at 2 years when they did not get azacitidine. So this tells us that azacitidine not only helps prevent transformation to leukemia, it helps increase the blood counts and decrease the transfusion requirement, but it also makes patients live almost twice as long. So when you look at these survival curves here, this red line is the conventional care arm, and the blue line, as it separates out nicely, is the azacitidine arm. Now, if you look right here, the question is, what if we could provide a curative option early and not have to see all these people here succumb to the disease? And I think that's where the best explanation and the best purpose comes in for allogeneic stem cell transplant. The whole point of a stem cell transplant is to give clean chemo-naive cells. We know with MDS we are dealing with a diseased bone marrow, so we want to replace that bone marrow with another bone marrow that's fully functional and able to differentiate and make the cells that the MDS bone marrow was not able to. The other thing that's very important with a transplant is this graft versus tumor effect. Remember, the job of an immune system, which is essentially most of the bone marrow, the job of this immune system is to fight off anything that's different. Most of the time, we think of the immune system's job as fighting off different bacteria, fungus, and virus. One of the lesser known jobs of the immune system is actually to fight off cancer. So when a person has MDS, the thought is that their particular immune system has not been able to recognize the cancerous cells or the cancerous MDS, and it doesn't kill it off because the MDS cells almost mask themselves as a normal cell. So when the immune system is doing its surveillance and looking around, it sees this MDS cell and says, this is close enough to a normal cell, I'm going to let it live. But the fact of the matter is it's a cancer and it continues to grow underneath the surveillance of that patient's immune system. So when we do a bone marrow transplant, we are recognizing that that immune system is not very good at finding the cancer and killing it. So why don't we swap it out for a different immune system? That immune system can go in and say, this MDS cell is not supposed to be there, I'm going to kill it. And that phenomenon is called the graft versus tumor effect. So just kind of, again, looking through the bone marrow, right here, this is just a little pictorial from the National Cancer Institute website. This is a little pictorial of the bone marrow, and inside the bone is where the marrow resides, and inside the marrow is where all these cells start to differentiate. So here we have the baby stem cells, and then they slowly differentiate into all the white blood cells, platelets, and then also all of the infection-fighting cells. And this is a very systematic process. And these cells also go back into the bone marrow and recognize any cancer cells, and they're supposed to kill them. So the transplant actually wipes all this clean and inserts a brand new set of stem cells that can go in and do this surveillance. So a little bit more on the graft versus tumor effect, just to put it into a picture form. When you have the donor T cell, so the donor immune system, it's got little proteins that sit on the surface of the cell. And those proteins go around doing their surveillance, trying to recognize bad cells. And once it sees something that's not supposed to be there, it attaches to it and it kills it. And that's called the graft versus tumor effect. Now, these T cells don't know the difference between the bad cancer cells and sometimes good cells that are needed for life in the patient. So things like the skin, the liver, the colon. This donor T cell is not used to that particular skin or that particular colon. So it's going to want to attach to that and try to kill it off. So that is the flip side of the graft versus tumor effect, and it's called graft versus host disease. So it's when the new immune system or the transplanted bone marrow is recognizing normal tissue on the host and trying to kill it off because it thinks it's different. So what I tell patients is when we're thinking about a stem cell transplant, I always explain it as graft versus host disease is the price that you have to pay to get the graft versus tumor effect. So the way we first find a donor is we want an immune system that is different enough to kill off the MDS, but not so different that it starts to recognize liver and colon and skin as foreign and tries to kill that off in the graft versus host disease process. So we want an immune system that's just close enough, and we find that the fingerprint of the immune system actually sits on the 6th chromosome of the chromosome complement. So every person has a little fingerprint that kind of identifies their own immune system. And what we want to do is match that chromosome up with somebody else's as close as we possibly can, so we're reducing graft versus host disease. But knowing that even within a fingerprint that's the same in most areas, there are other parts that will be different. And those differences are the ones that are going to help mediate the graft versus tumor effect. So the way we do this is obviously we try to go with a sibling, because you inherit half of your chromosomes from mom and half from dad. So there's a 1 in 4 chance that any patient has a sibling that will be a full match. Now, not all patients have siblings. Not all patients have siblings that are matches. And then some patients have siblings that are matches, but they're too old or they're too sick. So what do we do in that situation? In that situation, we go to a national donor bank called the National Marrow Donor Program Registry, where people out of just the goodness of their heart say, if somebody needs a bone marrow, I'm willing to donate. And we should know here that, remember, it's a fingerprint that's individualized to every single patient. But a lot of times there's these commonalities that occur within patients of different races and different ethnicities. So generally speaking, Caucasian patients, if they go into the registry, they're going to find other Caucasian patients that are closely linked and have a similar fingerprint as they do. Same thing goes with African American or Hispanic patients. The downside to this, though, is that since these things travel along the lines of race and ethnicity, patients, this registry is mostly made up of Caucasian people. So people that are Caucasian have a higher likelihood of finding somebody with a similar fingerprint or a similar match than compared to those that don't make up a majority of the registry. So once we find a donor, what process is there? So for the donor, they have to undergo a stem cell collection. Most of the time, they get injections in the belly or the arm with a growth factor that helps their immune system grow. And it basically pushes their bone marrow into overdrive, allowing the bone marrow to make nice, healthy stem cells that spill out into the blood. Once that happens, the patients donate their bone marrow. And as the patient is donating the bone marrow, or as the donor is donating the bone marrow, the patient is in the hospital getting chemotherapy. This chemotherapy is meant to wipe the bone marrow clean, to get rid of as much MDS as we possibly can, and also to suppress the immune system of the patient, so when the donor cells come in, the patient's immune system does not reject them. So that's 2 reasons we give that chemotherapy. So from a donor's perspective, what happens is once they take those shots and their immune system is nice and beefed up and these cells are spilling into the blood, we hook them up to what looks like a dialysis machine. So one IV in one arm, another IV in another arm. It pulls the blood out, spins it through the machine, and then takes out the white blood cells that it needs and returns the rest of the blood back to the patient. So when that happens, the patient's not losing anything or the donor is not losing anything that's vital to them. It's actually, they're only donating what we force them to make with those growth factors. And then that little bag of white blood cells that we collected, that gets transported to the patient's room for the actual transplant part. And in terms of the transplant, it's just hanging the little bag of white blood cells and allowing those cells to make it back into the patient's bone marrow. So I make it sound very easy, but it's actually quite an involved process. And up until the point of the transplant, it's not very difficult on our patients to undergo this chemotherapy and to undergo the infusion of the transplant cells. However, the trouble comes afterwards, because now we have given chemotherapy to wipe the bone marrow clean. The new cells haven't had a chance to grow. And so there's about a 14-day period where our patients have no immune system and no ability to make any blood. And at the same time, these new cells are percolating in the body, going around finding things that are different and trying to attack them. So there's a risk of infection, bleeding, and also graft versus host disease. So these are complications that can occur with transplant. And the one thing we do not want to do is cut somebody's life short with a transplant and knowing that they would have lived longer without the transplant. So it's very important to kind of tease out when is the correct time to transplant somebody. When is the time that we know that the risks of the transplant are much less than the benefit that the patient can get with a bone marrow transplant. So the American Society of Bone Marrow Transplantation actually put out a consensus statement a few years ago talking about when patients should get transplanted. We know that patients that have a high-risk RIPSS score, so ones that are going to transform into leukemia fairly quickly, they probably need a curative transplant quite soon. Otherwise, they would eventually develop leukemia. There's also a second population of patients, low-risk patients that had very low blood counts, were put on azacitidine, but now the azacitidine doesn't work anymore. So after azacitidine, there are no standard of care options. So that we've kind of run out of other options for these patients. And so that's when we think about transplant for them. So really, early transplant should be offered to patients that are considered high risk or low risk patients that have been refractory to any kind of treatment. Really, though, there's so many different populations of people that can have MDS. There's older patients that are very fit, older patients that are sick, that would not do well with the chemotherapy at the beginning of transplant. So there's so many little populations that it's hard to make a broad statement on exactly what to do. So this consensus statement doesn't actually give any recommendations on the type of chemotherapy to use, what type of donor we should use, and what we should do afterwards to help prevent any kind of relapse after the transplant. So when we look at this study with the timing of transplant and survival, this is how you break this table down. So on this side, we have the risk of the transplant or risk of the MDS per the RIPSS score. And then we look at those patients with the low risk and we look at their survival if they were diagnosed with their MDS and were immediately taken to transplant, or if they were transplanted 2 years after diagnosis, or if they were transplanted when their disease started to progress. So we have 4 different populations: low, intermediate 1, intermediate 2, and high risk. And we looked at their survival in years based on at what time point they received a transplant. We can see here that the low risk patients, if they were offered a transplant immediately after diagnosis, their survival on average was 6.51 years. When looking at giving transplant at the sign of progression, meaning we tried everything else, the disease is not responding, now let's transplant, we see that those patients live longer. So the conclusion from this is that if you have low risk disease, it's better to transplant at the time of progression rather than immediately after diagnosis. And then switching gears to this bottom side over here with the high risk patients, we see that if we wait really long time and we wait for them to progress on their chemo, that their survival is 2.7 years. However, if we find high-risk MDS and we immediately take those patients to transplant, they have a much better survival. So the downsides to this analysis is that it was done before the advent of hypomethylating agents. We do have some preliminary data to show that giving the hypomethylating agents, sometimes in the high-risk disease with higher blast counts, actually improves a little bit of the response rates and the relapse rates. And also this only included patients that were less than the age of 60. Nowadays, we are transplanting patients up to the age of 72. So age really puts a wrench into a lot of these numbers because we know that the older you are, there's a chance of having complications. So these numbers might be different for somebody who had low-risk disease and was transplanted at the age of 72 when they progressed. So the treatment options for patients who are unfit for allogeneic stem cell transplant, that's actually a big group of people because we know that MDS is largely a diagnosis of patients that are over the age of 60 or 65. And remember, I just said a couple minutes ago that we routinely transplant patients up to the age of 72, but we have a good amount of people between the ages of 72 up to 90 that have a diagnosis of MDS that are just too old to get a transplant because we know transplanting at an older age can increase mortality. And if we know that Vidasa or azacitidine is not one of those drugs that can provide a cure, what other options are there? So that's where I think the clinical trials really are advancing the field of MDS forward for those patients that do not have an option to get an allogeneic stem cell transplant because they cannot tolerate the complications of it. So there is hope for this very large group of people who do not have a curative option available because we know that there are many more clinical trials that are available. So just kind of looking at the FDA approval of all of the different therapies that are available for MDS, back in 2005, 2004 to 2006, it was a really big few years for MDS because there was an FDA approval for azacitidine, which is the study that we reviewed just a few slides ago. Its cousin drug, decitabine. Lenalidomide, which is an oral chemotherapy that is meant to be used for a certain type of MDS called 5q-, and then also iron therapy or iron chelation therapy, where we give so many blood transfusions to patients with MDS that they actually end up having iron overload, and that iron deposits in their liver and their pancreas and their skin, and that's a source of morbidity and mortality. So back in 2005, a drug that helps leach the iron from the body was FDA approved. So you can see here that we go nearly 15 years without any kind of new therapy that was FDA approved. Just recently, actually, luspatercept was FDA approved for the treatment of low-grade MDS with anemia. So we can see that there's this big gap that occurs in the middle of all this. So what have we been doing in all this time? In this time, we've been developing alternate ways to treat MDS and to treat people who have MDS that is refractory to this FDA-approved chemotherapy of azacitidine or decitabine. And the last few years have actually been quite productive in finding newer therapies and getting clinical trials up and off the ground. Some of the ones that I'll talk about include immunotherapies. So immunotherapies are drugs that will activate the patient's own immune system to recognize the cancer as bad and kill it off. Many of you have heard of immunotherapies for things like breast cancer or lung cancer, and it's curing patients with stage 4 disease. So those same immunotherapies are now being tested in the MDS space to see if we can activate the immune system to recognize these MDS cells as bad and kill them off. There's also targeted therapies. Remember, you can have mutations in the DNA that prevent cells from maturing and differentiating properly. So in this case, with the targeted therapies, if we have a mutation for which we have a drug that recognizes that mutation as abnormal and kills it, that's actually better than treating with chemotherapies because chemotherapies don't know the difference between good and bad, and it goes in and kills everything. So there's lots of side effects that come with that. But with a targeted therapy, it's a smart drug. It knows the difference between good and bad. So it would go to just the cells that have that mutation and kill those off. So we see that these types of targeted therapies are actually being looked at in clinical trials. The other big thing that we have looked at now is oral therapy. These two drugs up here from 2004 to 2006 are actually IV or subcutaneous injections. So that commits a patient to coming into clinic 5 to 7 days a month and getting an injection. And so their travel time, their work time, it's all kind of cut into this full-time job of being an MDS patient. But now there are oral forms of azacitidine that are in advanced studies, and also of decitabine that are being looked at, which I think are equally effective, but offer quite a bit of quality of life to patients since they aren't tied to the IV pole coming into clinic. So this is a very busy slide, but it's meant to give hope. And these are all the new ideas that are out there to help treat MDS. So looking at this being the MDS cell, these proteins that are all the colored boxes are all the proteins that are required within a white blood cell or within a stem cell to help it mature. So we can see it's not an A to B process. It's actually a multitude of proteins that all work together to create differentiation, to create normal bone marrow maturation. So in an MDS cell, one of these proteins could go bad or multiple proteins could go bad. So that's where we're looking at a lot of these different mechanisms of blocking the proteins or enhancing the protein's function to help with the differentiation. So we kind of talked about some of these. Right here, there's a particular mutation called an IDH mutation. We have a drug that is targeted towards IDH. So we have clinical trials, and we also have FDA indications for leukemia for IDH inhibitors. We see here, this is the usual hypomethylating agents that we talked about with azacitidine or decitabine. We have other types of cousins of hypomethylating agents, which can help with the DNA. These are in clinical trials. We have a combination of these, so we can put these backbone therapies together with other types of drugs that we know affect proteins. So we have quite a few of these clinical trials that are available here at UT Southwestern, including IDH inhibitors, the pevonedistat, immunotherapy, and antibody therapies that are available. So now the push is to either combine these newer drugs with the backbone that we already know is effective, or using other combinations, what we call novel combinations, to help stop MDS from turning into leukemia and help prolong survival. So in summary, high-risk MDS is defined by low blood counts, high blast count, and lots of chromosome abnormalities. It has to be treated because there's a high risk of transformation to acute leukemia, and because there's quite a few complications that can occur with low blood counts. Hematopoietic stem cell transplant is the only curative option, and the timing is actually very important. So not all people should get a transplant with the diagnosis of MDS. It really depends on what their risk is, and it also depends on what their age is and what their underlying health status is. And the reason is because if we don't have an option to transplant, there's actually lots of new clinical trials, new clinical drugs that are being tested every day to look for other options that are better than the standing therapy of azacitidine or decitabine that we have. So my hope here is to provide patients that have high-risk MDS with a outlook on what their disease is like, and also to give them hope that there are so many new trials and so many new drugs out there that we aren't going through that 15-year silent period from 2005 to 2020. I think things are going to exponentially get better, as I showed you in that last slide, with all the different drugs that are out there to target different mechanisms of MDS. So it is actually an exciting time to treat MDS because big things are going to be happening. Thank you.
A 72 is a very soft cutoff. It really depends on the institution, and it more so depends on the individual patient. I think the patient that asked the question started off saying, "I'm in great shape," and I think that is probably has the most weight when deciding when to take somebody over the age of 70 to transplant. What are their other medical comorbidities, and how functional are they? So yes, there are institutions around the country that do transplants on patients over the age of 72, and there is absolutely nothing wrong with that. If you are healthy enough and don't have a lot of medical comorbidities, transplant should be offered. So that is a decision between the patient and the physician treating the patient, because there are many trials, as you saw in that last slide, that are available now at large academic centers. Each trial has a different type of drug with a different mechanism of action. Some trials are only geared towards certain types of MDSs with certain mutations. And another big thing is I think this weighs heavily on patients, is what phase is the trial in? So trial phases can go from phase 1 through phase 4. And phase 1 is when the drug has just been developed, it's being studied to look for the optimum dose and to look for side effects, whereas stage 3 or phase 3 trials are actually very advanced trials where we know everything there is to know about the drug. Now we really just want to know, is it better than what else is out there as a standard? So some patients have a lot of trouble looking at the earlier phase trials because they are considered more experimental, whereas other patients have trouble with the later phase trials like phase 3 because usually those are randomized, where 50% of the time you get standard of care or you do not get access to the study drug. So some patients want to be a part of a trial where they have always will be on the treatment drug. So those are conversations that go on between patients and doctors. What is their disease? What type of trial is this? And then the third thing is, how much does it require on the patient's part? Some of these trials require inpatient stays. Some require 8-9 day hours in the clinic with lab checks every hour. So there's a lot that goes into it. And it's more of a nuanced decision now that we have more options available in the clinical trial arena than we did 5 or 6 years ago. I am not sure why there would be iron overload related to MDS if there's never been a transfusion. There are other causes of iron overload, namely genetic causes that prevent patients from excreting the proper amount of iron. So and that's called hereditary hemochromatosis. I think there should be a workup for that to make sure there's no mutation in the genetic code that is resulting in this patient acquiring more iron. But if there's never been a blood transfusion, then that iron overload is likely not related to the MDS. No, unfortunately, there are no targeted therapies for those 2 mutations, but there are lots of other clinical trial options for mutations that don't have a particular pharmacologic target. So the fact that you've made it 22 months without the MDS coming back, I think, is a testament to how great treatment has come. Most people, I would say, lose their response by 12 to 15 cycles if they have high-risk disease. But that doesn't mean to say that there are not long-term survivors and long-term responders. I actually have a couple patients that are up to cycle 45. I have a patient that's in the mid-30s for their cycles. So there are plenty of high-risk patients that are going 3-4 years on maintenance Dacogen and doing very well. Because it's different from regular chemotherapy, and that's what I was trying to impart in the beginning part of the slide when I was talking, or the beginning part of the lecture when I was talking about methyl groups and carbon groups. Because with normal chemotherapy, the job of the chemotherapy that most people think of with things like breast cancer or lung cancer is that chemotherapy goes in and it kills the cell. And that's why we see so many side effects from it. It just goes in there and kind of like a nuclear bomb, kills off the cancer cells and kills off everything else that's rapidly dividing. And that's the point of what we call cytotoxic chemotherapy. Just goes in there, damages the DNA so badly that the cell dies. And that's the normal chemo we see. This type of chemo with the Vidaza and the Dacogen is what we call epigenetic therapy. It does not damage the cell itself. It only takes off that tiny little methyl group that's sitting on the DNA. So that process takes a little bit longer. You have to cut off that methyl group. The DNA then has to be unwound, and then the proper genes have to be expressed to make the right proteins. So that process can take up to 6 to 9 months. Whereas with regular chemotherapy, it's more of just like almost like an antibiotic where you go in there, kill off the bad cells, and then they don't come back again. So it's a different mechanism for therapy, because we know the issue with MDS is more maturation of stem cells and inability of the proper DNA to be expressed. And that's where the target is. So no, and I didn't go into that. That's a very good question. I didn't go into that for time's sake, but we want somebody that is a 8 of 8, or sometimes we even look at an extra couple spots or a 10 of 10 match. So that's always our hope, is to have a sibling that's a full match. But like I showed in that slide, not everybody has access to a sibling. Not everybody has access to a 10 of 10 match. And that's where we start then loosening up our standards a little bit and saying, well, what if we do a half match? So with a half match transplant, we use a relative that only has one half of the immune system fingerprint that is the same. So remember, you inherit your immune system fingerprint from mom and dad. So half is from mom and half is from dad. And there's a 1 in 4 chance that you inherit the same half. But there's also a 50% chance that you've inherited at least one half the same from a different parent. And that's called a haploidentical transplant. So we often do those so that are 50% matched. And there are unfortunately people out there that don't even have haplo options. And that's when we do what's called a mismatched unrelated donor transplant. And we loosen it up a little bit and say, okay, we can't find an 8 of 8, now we'll do a 7 of 8. So we treat those a little bit differently because we know those immune systems are a little more different than we would normally want. So we want to match as much as we can in terms of blood type and age and things like that. And we also give chemotherapy after the transplant to quiet down the cells that are transplanted so they don't go crazy and cause graft versus host disease. So there are little things that we can do to help a 7 of 8 or a 9 of 10 transplant along and have the best outcome it can. So it's often done. Yeah, so patients that have progression or relapse of their MDS after a stem cell transplant most certainly do have options afterwards. And those, however, will be in the form of a clinical trial. We know that giving chemotherapy after relapse, after a stem cell transplant with things like Vidasa or decitabine is not going to be as effective. And that's where these novel therapies, I think, have a huge role. And a lot of these clinical trials will allow patients that have relapsed after a transplant, as long as they don't have long-lasting effects from their transplant with things like chronic infections or graft versus host disease, these options are available to them. I think a lot of it had to do with the understanding of the disease. In the beginning, we knew about these methyl groups, we knew about the DNA, but now there's been so much growth in the field of genetics and finding these mutations that drive the disease that now we've actually, in the past 10 years, been able to unwind all of the DNA, identify all of the genes that are responsible for maturation and differentiation, and now we go after that target. So I think the reason there's just been a very huge surge in all these treatment options is because we now have a better understanding of the mechanism of MDS, whereas 15, 20 years ago, we really didn't know more than just the fact that it was not maturing properly. Yes, there are some novel agents that work better with some mutations, and that's called a targeted therapy. So I briefly talked about one of them with an IDH mutation. So IDH is actually an enzyme that's required for metabolism of the cell. And when that mutation occurs, the new protein that it makes is considered an oncoprotein, meaning that protein can cause cancer, and it causes a leukemia or an MDS. So we have a drug that targets, or we have two drugs actually, that target the IDH mutation. And when the patient takes that drug, it actually inhibits that mutated IDH and prevents that bad protein from being formed. So that is actually being looked at in clinical trials for MDS. We have other types of mutations that can occur. One of the other most common ones is a mutation called FLT3. And that is a mutation that when the protein is mutated, it forces cells to hurry up and grow faster. And so we have a drug that targets that FLT3 mutation and shuts down the growth of the MDS cells. Kind of taking all of these things into consideration, there's now what we call umbrella clinical trials that are being formed, where we read out the genetic code of the MDS cells, find all the different types of mutations there are and try to pair them with a chemotherapy that we know is from science more effective in that particular subgroup than others. And the Leukemia Lymphoma Society has already started this with AML, and it's called the Beat AML trial. And now there's a push to do this towards MDS, to find these genetic mutations and target and tailor therapy to those. So that's a difficult question to answer unless I know what the presentation blasts were, what the presentation mutations and chromosome abnormalities were, because there are people that can have very high risk disease and the decitabine or the azacitidine knocks them into remission, brings their blast count down. But the risk of transformation and the risk of relapse is what we find in the beginning. What was the blast count? How low were the counts? What were the chromosomes? So the RIPSS at diagnosis is what dictates long-term outcome, and I think I'm missing that from this particular question. So if it is truly MDS and it's just anemia, then that is an observation as an appropriate treatment for this MDS. So I didn't go into any of the low-risk MDS treatment options, but many times there's a small amount of MDS in the bone marrow, but it's not causing any problems. The blood counts aren't low enough. So we would just watch it every few months. And if the anemia gets worse or if other blood counts start to drop, then we talk about treatment. But I've had patients that have been on observation like this for 9 or 10 years and are still on observation. And we don't do anything because the MDS is that slow growing and that indolent. That is a good question. It's up with the FDA right now, but I don't really have a timeline on that. The studies that were already done show that it is equally effective and equally tolerated as IV decitabine, though. There's actually a very black and white way to look at comorbidities when assessing for transplant. It's called the HTCI score, the Hematopoietic Stem Cell Transplant Comorbidity Index. And what that does is, it was a study that was out of Fred Hutchinson Cancer Center in Seattle, where they took thousands of people that underwent an allogeneic stem cell transplant, and they looked at which ones survived and which ones didn't. And within the ones that didn't, what medical comorbidities did they have? And it turns out there's about 11 or 12 things that can increase your risk of death or complications with transplant. So things like strokes, heart disease, kidney disease, diabetes, rheumatological problems like lupus, peptic ulcer disease, depression, anxiety, elevated liver numbers. So anything that damages an unrelated organ, but that organ is responsible for kind of helping with the reserve after transplant, go through and complete all the different comorbidities and come up with a score. And that score tells us what your probability of some kind of transplant-related mortality would be in the first 2 years. Kind of like the RIPSS, but geared towards allogeneic transplant. That's a really good question, and that depends on what the RIPSS score is. For high-risk patients, the benefit can last anywhere from, I shouldn't say it can last, on average would last 9 to 15 months. But there are patients with high-risk MDS that have, like I talked about with one of the first questions, where I have patients that have gone 40 months and are in a complete remission, normal blood counts, and are traveling around. So that is institution dependent. Some institutions, like the first question, I think the patient was from Moffitt. They obviously transplant patients that are a little bit older. At our institution, we do use 72 as our soft cutoff, and the patients would have to be in extremely good shape to get a transplant over the age of 72. There are also tests that are done prior to transplant where we look at heart function, we look at kidney function, liver function, and we decide if there's any other organ abnormality. So there are some black and white tests that are done that will dictate whether or not a patient should be offered a stem cell transplant. Again, I think it depends on the risk. So if we are transplanting for low risk MDS or even high risk MDS where the blast count is relatively stable, there is no point in subjecting yourself to a different therapy and opening up the possibility of having side effects that would make you sicker before transplant. So if you are stable, your disease is stable, and we can wait a few months, I think it's reasonable to not do anything or to continue whatever therapy you're already on and just wait for COVID to kind of settle down and open back up the transplant options. Now, if in this time of observation, we see that the disease is advancing, the blast count is going up, the blood counts are dropping, and by days of azacitidine or decitabine are not an option, then I think a clinical trial can be considered. And also, a lot of these clinical trials, they have caveats in the inclusion and exclusion criteria. So we'd have to be very careful about which clinical trial we consider, because some clinical trials do not allow patients that are going to go on to transplant. They only want patients that do not have a transplant option and need some kind of long-term therapy. So because of that, I would say if things are stable, I would wait for the pandemic to settle down a little bit and then go to transplant. They're not targeted therapies per se for those mutations, but DNMT3A is actually the enzyme that azacitidine and decitabine work against. So azacitidine and decitabine are actually considered DNMT3A inhibitors. So that's probably the most targeted we're going to get for that, but otherwise there's nothing else. I think I've already kind of gone over how long on average, between 9 to 15 months, most often around 12, and that's the average. So it's definitely not to say that if you make it 15 months, it's going to stop working for you then, because there are patients that are out there that have had long-term responses for years. And so if it's working, we wouldn't change anything. Polycythemia vera post-stem cell transplant. That's actually pretty rare. It's difficult to tell what the polycythemia is from. Is it actually a bone marrow problem where it's a mutation that's causing the bone marrow to grow more? And if that's the case, is it coming from the donor? Or there are lots of other secondary polycythemias that can occur from things like testosterone treatment, smoking, obstructive sleep apnea. And so I think before chalking the polycythemia up to a post-transplant complication, I'd want to make sure there wasn't a secondary cause. I do actually have an opinion on that. We do that quite a bit. So multiple myeloma is a very common bone marrow cancer, and even the precursor to multiple myeloma that we call MGUS is very common. So it is oftentimes that we see patients with multiple myeloma and we will go ahead and do the allogeneic stem cell transplant. I've done that a few times, and luckily the myeloma goes into remission with the allogeneic transplant. That's not to say that afterwards it can't come back, but we know that if you compare mortality to myeloma to MDS, MDS is more aggressive and more likely to cause mortality. So we want to treat that first with the allogeneic transplant. So a lot of it depends on the severity of COPD. We do pulmonary function tests to look at the lungs, and that's actually an important organ system to have functioning before transplant, because you can have attack of the new immune system on your lungs, which is called graft versus host disease of the lungs. So we are very careful with patients that have underlying lung problems. That's not to say that you can't have COPD and go to transplant. It really just depends on the severity. In terms of if we would transplant from a disease standpoint, I'd have to know more about the initial diagnosis and if the chemo that you're on right now is working. Because if it's working and we don't have a donor and the lung function is bad, then I think it's a reasonable thing to continue with the chemo. We know those are high risk markers for complications if exposed to COVID, and patients start to have the lung findings and the pneumonia that goes with COVID. So 30 to 35% is pretty low, and if that doesn't get better above, I would say 40, I would be hard pressed to want to do a transplant because of complications that come with heart failure. But there are clinical trials that are available that do not take into account heart function. So, and we have one of those at our center where if we have MDS that is refractory to azacitidine or decitabine, I have a clinical trial that doesn't require a cutoff for the heart function. So they're out there. There's not as many, but they're out there, and I would consider that over a stem cell transplant if the ejection fraction was around 30%. So some of the new emerging therapies are, so far there are none that are FDA approved. The ones that are FDA approved is the most recent one of luspatercept, and that is FDA approved for low risk MDS for patients that have a certain type of anemia. And the side effects of that luspatercept is that they're pretty tolerable in terms of everyday function. It can cause some nausea, it can lower the blood counts, but otherwise it's very well tolerated. In terms of some of the therapies that are coming up for higher risk MDS, in the clinical trials, it really just depends on the study drug, and there's far too many trials open to name particular side effects because those are all in clinical trials right now and not FDA approved. One of the first questions I had was a healthy gentleman that was the age of 77. So that obviously there's no hard cutoff. Our institution uses 72, but again, it's very much dependent on the underlying health of the patient. Now, that being said, I've never seen a transplant in somebody over the age of 78, but that doesn't mean that it hasn't happened somewhere else. There are. So one of the ways to do that is we take these anti-rejection medicines to quiet down the immune system so the new immune system doesn't attack the patient's normal tissues like the liver and the colon and the skin. We also give chemotherapy after transplant to quiet down donor cells so they don't go crazy. And so this is called post-transplant cytoxin. And this has kind of been an adopted practice over the past couple of years for anybody getting a transplant to get chemotherapy on day 3 and day 4 after transplant to help reduce the graft versus host disease. But again, it really just depends on the risk of the disease and what other factors there are if the patient can handle the cytoxin. And it's an individual decision with the transplanter and the patient. Yes, so there is. The conditioning regimen is the chemotherapy that goes in before the transplant to wipe the bone marrow clean and suppress the patient's immune system enough that when the new transplanted cells come in, they don't reject them right away. In the beginning, when transplants were first done for MDS, they were done with what's called a myeloablative regimen, where it was just high doses of chemo that was kind of like a nuclear bomb and went in and cleaned everything out. Obviously, MDS is a disease of patients that are older, and so most older patients couldn't handle that very significant heavy chemotherapy. So now there's an option of reduced intensity conditioning, where it doesn't go in there and just clean out the bone marrow. It just goes in there and suppresses the patient's immune system enough that when the new cells come in, those new cells kill off the entire bone marrow. So more than killing the patient's own bone marrow, we are allowing more of the graft versus leukemia effect to take place and to clean out the patient's bone marrow, and that does the work instead of the chemotherapy. I think the hardest part about MDS, at least talking to the patients when they come in to see me, the hardest part about MDS is telling patients that there is no cure. And what I often say following the fact that there's no cure is that just because there's no cure doesn't mean there's no treatment. And even though Vidasa and Dacogen provide on average 9 to 15 months of remission, I would rather patients focus on those that can get a long-term remission and also focus on the fact that there are quite a few new clinical trials out there that are targeted and that are taking advantage of the diseased pathology of the MDS cell and focusing on that rather than giving high doses of chemotherapy. So there's lots of new therapies out there, and the biggest thing I want people to take away from this talk is that there's lots of hope. Whether or not transplant is an option, there's lots of hope, and there's options in terms of clinical trials, and we just have to have you reach out to institutions like the MDS Foundation to connect you with centers that have clinical trials beyond decitabine and azacitidine. I always tell patients, that's a really good question, and I always tell patients that healthy in is healthy out. So whatever your best health state is when you admit for your transplant, that's the best you're going to be for a while. And there's going to be a decline no matter how healthy or how young you are. There will be a decline during transplant. So if you are on your way to getting a transplant, I think the best thing to do is eat healthy, try to get your muscle mass up, be more active, exercise, because you will notice a huge drop in your functionality during that 3 to 4 week hospitalization. And the best way to do that is to make sure you have a huge reserve of muscle and energy and functionality. So when you do go home after your transplant, you haven't dropped so much that you're needing extra care.
For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, look out for an email that will provide you with a link within 4 to 7 business days. This concludes today's program.